All right. Good evening, everybody. Thank you for joining us tonight. Give it just another 10, 20 seconds. All right. All right, let's kick this off. What an amazing turnout, everybody. Over 700 signed up. So welcome to Peptides in Clinical Practice. I'm Chris Gross, the National Sales Director at Optimal Balance Pharmacy. With me with Optimal Balance, we have Ken Lavelli, my co-sales director, partner in crime, and then Rick Manuel, also with Optimal Balance, one of the owners. Peptides have quickly become one of the most talked about areas, integrative and longevity medicine, with growing interest in areas like metabolic health, recovery, body composition, hormone optimization, which we'll get into, and healthy aging. So tonight is really about education and the clinical perspective. So really understanding where the research is evolving, what providers are seeing in practice, and how these therapies are being thoughtfully integrated into patient care. So we're super thrilled to have you tonight. Thank you for joining us. We really appreciate it. I'll do a little quick intro on us as a pharmacy, kind of how it will work, and then I'll introduce Nico, our speaker. So quick introduction on who we are as a pharmacy. So Optimal Balance, we're a 503A sterile and non-sterile compounding pharmacy licensed in over 30 states, based in Houston. Owners Rick and Chris built this pharmacy really with one goal in mind: serve clinicians and patients with quality, compliance, and consistency. So you'll hear from us a bit more throughout the evening, but tonight really isn't about us. Tonight is about Nico and his presentation and medicine overall. So again, this webinar is clinician focused. We're going to keep it on the clinical side, patient selection, protocols, formulation, real case discussions, and this is the value we really want to deliver tonight. So how it will work, quick housekeeping notes. So Nico is going to give a presentation for roughly the first part of the hour, and we're saving Q&A for the end. So please put your questions in the chat. If you have a question as you're going, drop it in the chat, and we'll work through as many as we can in the last 30 minutes. So we are recording tonight. This replay will go on YouTube either end of this week or early next. So keep an eye on your email. You'll get a link to that. And then two things that we'll send out as well. First, if you're a clinician and interested in, or a business owner and interested in opening an account with us at Optimal Balance, we'll send you a quick jot form to fill out. So it's nice and easy. We'll assign you a rep to reach out to you and get you, onboarded properly. So second, if you are a clinician interested in HRT University, which Nico is going to touch on during his talk, we'll make sure you get connected with him after. So that's pretty much the housekeeping items. And most importantly, so introducing Nico Mislay. So now to our guest. So he is a board certified family nurse practitioner and the founder of HRT University and Apollo Health Optimization. He has built a thriving HRT clinic from the ground up. He is a national speaker on HRT, functional medicine, and mental health. He's consulted with hundreds of providers across the country. I bet that's probably thousands at this point. And what sets Nico apart is really, he's not just teaching theory, he's running the practice he is teaching about. And that is why we wanted to have him tonight. We're super honored, super grateful. Nico, thank you for being here, and the floor is yours.
Chris, thank you very much. And thank you to the Optimal Balance family for letting me crash your party. Quick note, if anybody can't hear me, please let me know. My microphone was crashing up until like the last few minutes here. We've got everything rock and rolling. I've got some notes over here, so I think I'm ready to go. For those of you who are joining, and you know a little bit about me, again, I own HRT University, which is our beautiful educational platform. And one of the things that people have asked me to talk about for probably the inception of HRT University is, when are you going to do something about peptides? And so this has been a nice little way to sneak peek. We're working on something grand on that front, which is really exciting. But it's for good reason. Everybody wants to know about this stuff, and I think you should know about it. What I don't want to see happen with peptides is what I think has happened with HRT, frankly, for a really long time, which was, a stigma behind it. There's some, kind of gray area in the whole space, and everything just gets the kibosh put on it. And really, at the end of the day, it's just patient suffering. And I think they're suffering needlessly. So I think peptides are absolutely incredible, just like hormone replacement therapy. And so I want to kind of present that to you also, this idea that Peptides aren't these scary foreign things that we can't utilize in our practices today. So can everybody still see my slides okay? Chris, I'm looking at you especially as I get into this.
Beautiful. Looks great.
Okay, amazing. All right. So again, a little bit about me. Family nurse practitioner by trade. I've been doing this for 10 years now. I was really fortunate. I literally started in integrative and functional medicine. I knew really early on that I just did not want to have anything to do with the conventional side of things, especially as like chronic care goes, right? I didn't really want to work in the primary care offices and stuff. And so I had some amazing mentors, and these were guys and gals who were, way beyond their years and wisdom and whatnot. And so I really got to learn a lot about hormones and nutrients and vitamins and minerals and how we can use all these amazing things. Of course, peptides also being that similar fold, right? And at the time, there were things I was using that I didn't realize were peptides. That's how, again, much I've grown even in just the span of 10 years. So I have a beautiful clinic here in my home state. We were brick and mortar, now we're telehealth, which is exciting. So it's just my wife and I, and we have a couple nurse practitioners, which is a total blessing. Again, HRT University, that's our now joint accredited education platform for licensed medical providers, which is, again, another huge blessing in my life. And of course, the other being just a husband and a father. That's my favorite job in the world. But you'll see on this slide, one of the things that we really wanted to bring forward, and we didn't see a lot of, especially in the world of education, and especially inside of our little world of wellness and health optimization, is this approach of like, can we consider the physiology first and like the protocols and algorithms and whatever else second, right? That should always be our approach. And the reason to that is, I think in today's world, medicine has reduced down to, and you could feel it in the primary care offices, it's just protocols and algorithms. It's just checking boxes and flinging meds at people based on whatever algorithm that we're supposed to be following, whether that's from some, ACOG or American Heart Association or whatever. And again, I'm not saying that's all bad, but it takes away our ability to critically think and to explore and be creative and all those important things. And it's the fun part of medicine, right? My grandfather's a retired physician. He just gave up his medical license. He's like 95, so he's not going back to the hospital anytime soon. But, he always said, being a provider is being a detective, right? You're always trying to do what's best for your patient, and you're never, ever stopping that question of why is this happening? Why is this occurring? And sometimes that feels frustrating, but again, I think that's kind of the whole fun of it. So that's kind of my reason why I love to bring physiology first. Can we make sense of what we're doing, and does it make it a little sweeter? So,
Nico, I was just saying, if you try killing
please.
try killing your camera, it might be causing some of the. We have a lot of people joining. We noticed that the slides are a little bit blurry. I think it's a bandwidth issue.
Sure. Yeah.
So potentially, maybe the presenters killing their camera might help a little bit, and
does that help?
It starts to stabilize a little bit.
Okay. Is that any better?
It just thinks we had a couple hundred people join all at once. It's causing some issue. I'll kill my camera as well.
Okay. All right. Let me know if that's still no bueno. All right. So most of you guys probably know this by now, but if you're asked what is a peptide, right? It's just a chain of amino acids of proteins, right? And these amino acids can be big or small, and I won't get into all that detail. I'll save that for the course. But a peptide is, and this is the analogy I like to use. If we think of hormones, because hormones are important in this context, hormones they're the climate, right? I live in the United States, and I live specifically in the beautiful state of Ohio, and we have this very temperate climate, right? And that's pretty much standard, right? We have our 4 seasons, and the weather's runs in a cyclical pattern and all that kinds of stuff. But peptides are the weather, right? Sometimes we have rain, sometimes we have snow, sometimes we have thunderstorms and things of that nature, right? They're these little blips, but they occur, and they're supposed to occur under the umbrella of the climate. Another analogy could be something along the lines of, okay, I work in a hospital, right? And the hospital has a PA system, right? So God forbid if there was a code on this unit, 10 floors that way, right? Everybody would know in the entire hospital. We can communicate broadly in that sense. However, as a nurse, I might come up to another nurse and maybe I hand them a Post-it note and say, hey, do you mind changing out this person's IV bag in, X and X time? Right? That's just little messages going on underneath the entire umbrella of the hospital, right? So that's the way I'd like to think of peptides. They're doing a very particular thing. They can do many particular things, but generally speaking, they're not having a what we would call totally pleiotropic effect, and that's a big fancy word for saying testosterone, for example, like it goes all over the place and it does all sorts of amazing things, head to toe, top to bottom. Peptides particularly don't share that necessarily, right? Some peptides do, again, have multiple functions, but mostly they're doing one very specific thing. Insulin, for example, is a really common peptide. Again, those of us who are in the world of peptides, most of us just kind of like stumble upon these facts like, oh yeah, insulin is a peptide, right? Oxytocin, most of us consider that a hormone, and it is, but it's also a peptide. So this is really interesting, right? So there are peptides and there are hormones. Some hormones are peptides, not all peptides are hormones, right? So it's kind of a part of our body's language, right? So this is another way I like to think about it. If I speak English, that's really cool and great, right? I don't speak old English, like I'm not a Shakespearean actor, although I would love to be maybe someday. But I speak a very modern version of English. And in fact, then I can layer technology on top of that. So I can text, I can maybe use emojis and things of that nature. And that is now what pharmacology is coming in and doing. Okay, so for example, GLP-1s, and I'll get to this in a little bit, GLP-1, we make this in our belly, they last for like a couple minutes, and then they're out of our system completely. Well, pharmacology comes along and says, I love the mechanism of this little peptide. I wonder if we could extend the life of it. Instead of a couple minutes, what if we extend it to 7 days? Right? So again, we're using something that's not totally foreign. It's native to our biology. I know what a GLP-1 is. My belly does. It's seen it a million times. But how can I amplify that technology? How can I make more of it? How can I utilize receptors that are across my body? So, right, we have GLP-1 receptors all over the place, in our brain, in our heart. And so now I can, again, amplify it, not just to say, Nico, stop eating so much, but also, Nico, repair heart, repair mitochondria, things of that nature, right? So we love peptides for that reason. And generally speaking, I'll mention this, most peptides have a short half-life, right? So it's a quick signal, and then it kind of clears. And so we don't have this tremendous tissue accumulation. It's not like they're floating around all the time. That is why, again, from a pharmacology perspective, and if you're Eli Lilly or Novo Nordisk, you want to create peptides that could last a little bit longer, just like we did with testosterone cypionate, for example, right? We added something to that testosterone molecule to allow our body to not gobble it up right away. It kind of exists for a little bit longer. So again, we're using some native things, but we're adding some new technology in. But at the end all be all, what we're really, really trying to do, what we're really trying to focus on is to keep the body doing what the body does and doing what it does best, right? So again, if we're thinking about this from a very high level view here, from hormones to peptides, I think this is really, really critical. When providers come to me and they say, Nico, how do I know, like, how would I know it's the right time to start presenting peptides to my patients? Because a lot of us probably get patients who come in, especially nowadays, where they're like, dude, I'm hearing all about all these peptides and maybe I'm a little bit overweight, or, maybe my energy's kind of down. Is there a peptide that could help? And it's a great question, right? Because there probably is, but are your patients actually optimized enough to really even warrant the question of a peptide, right? So that's always something we want to discuss first, and I'll get to that even more so. But hormone replacement therapy being one, right? Like, if your hormones are not optimized, then jumping to peptides right away for, say, a woman in menopause who's tired, well, we can throw MOTS-C at her and see if we can get her energy up. But what if we restored her estradiol and progesterone and testosterone and things, right? In fact, that'll probably globally, and based on the very fine literature we have, help that person really live a long, healthy, and qualitative life. Now, If there's still some leftover there, right? There's some leftover weight, there's some leftover fatigue, there's some leftover wound healing, whatever it might be, that is, I think, a really good and pivotal moment where we can now start adding in peptides, truly. Again, a GLP-1, a BPC-157, things of that nature. And we can base that and ground that on a really good decision, right? We have done things that are, from the hierarchy of needs, very appropriate. We've discussed diet and lifestyle. We're helping them sleep better. We've restored their hormone replacement therapy, section of the universe of their body. And now we're just going to get to some of the more nitty gritty stuff, right? And so again, we're kind of following the physiology that I talk about this, right? The application finds you, right? Once we've kind of gone through that hierarchy of needs for our patients, at that point, then we can start really doing all these fancy things with peptides. And I love that. And there are some really great use cases. Of course, if a patient, say, for example, is getting an ACL repair done or something like that. Well, of course, that's a moment in time where we can add BPC-157 without really thinking too much about it, right? That would be a great example. Certainly a morbidly obese patient. I mean, of course, I would love to optimize their hormones, but hey, a GLP-1 is probably actually going to be a really good positioning point for them. But what I'm getting at here is try not to be the provider, turn into the provider that's just throwing freaking peptides, 20 of them at one patient and seeing what sticks, okay? Because that's really just going back to, a lot of times what we would do in functional medicine, which is like, well, here's a laundry basket full of supplements and see if any of these help. It's just too much noise, right? So hormones first. Hormones are the foundation. And again, I'm biased, I get it, but they are so impactful that, again, if you want to do something that is just so unbelievably evidence-based, it would just make you scream from the mountaintops. HRT, baby. HRT is the way. And again, peptides amplify what is already present in that patient, right? Peptides are going to amplify the GLP-1s that they're already producing, or maybe just a little bit of, and really present that patient with a full force of their biology. They're precise, they're super powerful. And again, I find that a lot of patients, they pursue peptides first, or providers pursue peptides first, and we're just wasting a lot of that effort, because really what we should have done is probably start with HRT first. Okay, so again, just consider that, please. That's a very core principle within HRT University, right? Is always think about hormones. So I'll stop talking about hormones here a little bit. So again, remember, we're looking at targeted signaling with peptides. What is the physiological target? What am I trying to move? Okay, so again, we don't have to really question this too much, because we can go to something that we're already doing that with. Insulin is just such a good example. Here is a peptide, and again, sometimes we'll hear it called a hormone, and that's fairly accurate too. Here's a peptide that we have been using at this point. If you're a provider, we've practically been using this since the dawn of time, right? One of the OG peptides that has a very clear target and mechanism of action, right? I mean, we all know what a type 1 diabetes patient, especially a type 1 diabetes patient, but even some type 2 diabetes patients, what is it that would require them to get to a point where we might need to utilize insulin? Okay, well, broken pancreas would be one, right? Extraordinarily dysregulated blood sugars, and practically speaking, the absence of functional insulin and insulin sensitivity. So that's the physiological target. Now, again, outside of that, let's say it's a type 2 diabetes patient. Okay, well, we understand that this is a largely preventable disease and there's some clear things we can do. We might need to use insulin for that patient if they're just so far gone, right, that they're extremely overweight, extremely metabolically compromised. Using insulin is a great strategy and idea for those patients. But the goal would be, of course, can we get their foundation a little bit more solid? And I think HRT is a big part of that again, right? Can we get their thyroid optimized? Can we get their progesterone and estradiol if they're a female, or testosterone optimized? Again, and then going back to now, what does this patient need beyond the hormones? So is there still a physiological target that we need to be addressing? And GLP-1s, again, become a really obvious one, okay? So if you take a patient who is morbidly obese and we're getting their foundation solid, but we know, I mean, this is very clear in the literature, if you are morbidly obese, your risk of everything goes up, by 1,000 kind of thing, right? I mean, you are at much greater risk of just practically everything, anything you could die from. You are at extraordinarily higher risk if you are morbidly obese. And I can't think of a better way to physiologically target morbid obesity outside of course, some of the foundational things that we can do. I can't think of a better way to target that so precisely than something like a GLP-1. And again, I don't have to even speak to you guys about that, because I mean, most of us have at this point treated many patients, if not hundreds of patients, utilizing GLP-1s. Maybe we ourselves have utilized them and found the benefits there. So just always, again, think in the mind of how can we use this beautiful targeted signaling to affect amazing outcomes at the end. I think that's fascinating. So here's a really good example. Let's get into some of the other types of peptides. What other peptides would be considering? Well, any peptides that affect our growth hormone signaling and IGF-1, right? That axis. Growth hormone, again, it shouldn't be, but it is a controversial area. And again, that all kind of boomed along with testosterone back in the 80s, right, with the Olympics and all that stuff. And we had the ban across any type of substance that would be performance enhancing. And of course, growth hormone was put into that category. And I joke because anytime, in fact, Dr. Andrew Huberman said this in a tweet the other day. So I thought it was funny because he finds it funny. Anything that's ever been banned from the Olympics, you have to kind of sit there and be like, okay, that's probably a pretty good med. Like, it's funny because so many things that do get banned, there's a reason why they get banned. If they're performance enhancing in any way, it almost always means that in some capacity, it has a repair mechanism, right? An anabolic effect, which we love. And typically, a lot of times it carries a mitochondrial or metabolic effect with it too. And growth hormone is absolutely one of those things, right? The problem with growth hormone is that it does create, if you take human growth hormone as an injection, which is extremely expensive, it does have positive effects, more or less, but it completely shuts down that growth hormone axis, right? And that's not too dissimilar from what testosterone does, right, if we give it to a male. But needless to say, interestingly enough, researchers and pharmacy researchers, they recognized that, and they created things like sermorelin. And then the stepbrother of that, tesamorelin, and many other morelins, right, ipamorelin, and things of that nature. Why? Because they don't cause the same shutdown effect. What they said was, is there a way we can utilize a little amino acid chain that will signal to the body to go ahead and release its own growth hormone, and we can affect that significantly, how much is released, for how long it's released, which is amazing, and without shutting down that axis. Okay, so growth hormone, I think most of you already know this, huge effects on body composition. Generally speaking, much like any anabolic hormone, it increases lean muscle mass, decreases body fat. Unbelievable help with cognitive clarity, sleep. The amount of patients I utilize sermorelin is one of the most beautiful growth hormone secretagogues. A lot of people give it a lot of flack because it's not as potent as, say, ipamorelin or tesamorelin, but I don't care what they say. Sermorelin is amazing. If you have a 60, 70-something-year-old female who just can't seem to sleep, and we're giving her progesterone and sleep's gotten a little better, but she's still struggling, give her a little bit of sermorelin and just watch what happens. It is unbelievable. It's very gentle. It doesn't cause a lot of the joint swelling and things that we could get with some of the more potent stuff. And it absolutely enhances muscle tissue and all that stuff. Many of my mentors, they always said, growth hormone is kind of a bad name. When we hear growth hormone, we just think about bodybuilders and somehow it's just going to enlarge your face and your gut and everything's going to get huge. That could happen with crazy, insane dosing of growth hormone. But what we're talking about here is, again, more of a restorative effect, right? Using growth hormone to our advantage. And growth hormone really is a repair hormone. That's the mechanism. It is really bad at growing human beings in the sense of like anabolic drugs can grow people. If you take trenbolone, for example, you can get absolutely massive. It is very hard to do that with growth hormone, even growth hormone in and of itself. Okay, what bodybuilders use growth hormone for is for all the things that you see listed here on this slide. Okay, it is a recovery tool, and it's one of the best out there. Absolutely amazing. So again, Sermorelin versus Tesamorelin. But both of them again having quite a similar effect, so to speak, on the brain. Right, we're kind of stimulating the pituitary very directly. We call them growth hormone releasing hormone analogs. Okay, so these peptides, and this is where we have to be careful, because just because a peptide is a protein, it doesn't always mean it's native. Okay, so insulin, for example, is a native peptide. I mean, we literally produce it out of our pancreas. There are some peptides that are not native, but they're analogous to something that might be native. Okay, so we actually could now shine a light here on what would be like non-identical hormones. And of course, those don't always get a really good rap, especially for me. Your conjugated equine estrogen and things of those natures, right? So again, but that doesn't mean it's bad. And I want to be very clear about that, right? It's the same as antibiotics. We have really amazing, effective antibiotics. And there was this whole thing of like antibiotics are bad and they're the devil and never use them. Antibiotics are amazing, and they're amazing when they're used appropriately. Well, so can synthetic forms of medications, right? I use levothyroxine and leothyronine. Those are technically synthetic hormones. Now they have a relatively bioidentical structure to them. They have very similar effects, but they're not in and of themselves native. Okay, so a lot of the analogs are also in that same type of category. But so anyways, again, Sermorelin literally stimulates the pituitary directly, and it preserves what's called the pulsatile growth hormone release mechanism, right? So every single day we have this nice little pump of growth hormone overnight, right? Which is amazing. The body literally rests and recovers. Greatest amount of growth hormone is released, generally speaking, overnight. And this is also why we see growth hormone being so effective at sleep and recovery and body composition. In fact, a lot of patients will complain, especially with really high doses of not so much Sermorelin, but especially Ipamorelin and Tesamorelin. They may notice that if they take it during the daytime, they have kind of a sleepy, groggy effect. And that is because those peptides are so potent when they hit that pituitary and that growth hormone releases, you just get that kind of sleepy effect. So Tesamorelin says, you know what, let's take everything that Sermorelin does and like you literally dump steroids on it, right? So we're getting this really big extended half-life. So not only does it depend on how much growth hormone is released, but for how long it could be released. And again, both of these, Sermorelin was FDA approved for many years, especially for pediatric patients, right? Because we didn't want to give pediatric patients growth hormone by itself, because it would shut off that axis and have all kinds of other potential repercussions. So Sermorelin was literally developed for pediatric patients. So again, if we have to talk about how safe this stuff is, well, it made it through to an FDA-approved medication for a while. They removed it since then. But Tesamorelin is still actively FDA approved for HIV lipodystrophy, which is essentially that truncal adiposity or obesity that a lot of those poor HIV patients get because of the drugs that they have to take. So what does Tesamorelin do? Well, it takes the thing that growth hormone does and does really well, which is getting rid of visceral fat, and literally dumps fuel on it, like fuel on the fire, right? It is tremendous at getting rid of visceral adiposity and even helping patients with any type of non-alcoholic fatty liver disease. Absolutely amazing at that. You can't really find a lot of drugs that compete with Tesamorelin on that front. And again, this is one of the reasons why I'm saying, look, just because we can get some really good body composition stuff here too, we also need to be targeting patients who maybe have just NASH, right? Or MASH, either one of them. Like, this could be a great resource for these patients without, I mean, of course, diet and lifestyle, that stuff matters, but I mean, if you have a really bad case of non-alcoholic fatty liver disease, I can't think of, again, another really great option like Tesamorelin to just clear that at a rate that is just unprecedented amongst other medications. I would say most of you have to be at this point familiar with BPC-157 or body protective compound. So again, this is a peptide that is technically speaking native. It more or less is a peptide that stems from our gastric juice. So it's native in one sense, meaning that it was somewhat adulterated to again maintain its composure, because a lot of these peptides are so fragile by themselves, natively speaking, that again they just get degraded by enzymes or changes in acid and base so quickly. So a lot of times what pharmacologists and people have figured out is, hey, we can extend these by altering the composition of the amino acids, or adding things to that amino acid to extend the half-life, and so on and so forth. But BPC-157 again is notorious for helping with any type of soft tissue injury, acute or chronic, which is really helpful to know, right? Angiogenesis, it is amazing at helping new blood vessels form. A lot of people, controversially, this is where people freak out because they say, oh my God, hypothetically, isn't that kind of what cancer does? And would BPC potentially potentiate cancer formation if there is potentially even some cancer present? Again, I would argue, based on the mechanism of action of BPC-157, which I go into this in great detail in the course that's coming out, I argue no. I don't think that holds up with the mechanism of action of BPC-157. It is notoriously pro-mitochondria, pro-metabolism, in a way that heals metabolism, because it's ridding us of inflammation and things of that nature. That is kind of the opposite of what cancer is doing. Cancer is being fueled essentially by that inflammation. BPC-157 classically it modulates nitric oxide pathways, which again, if you're trying to heal something and you're trying to get nutrients and good blood vessel formation and dilation there, well, we would love to have a little bit of nitric oxide, wouldn't we? It enhances fibroblasts. It literally, in some of the rat and mice studies, it literally helps migrate tendon tissues, which is just unbelievable. When you see these little tears in the muscle like this, and then BPC is added and they go like that, it's just a really fascinating thing. And again, if you think about tendons and ligaments in terms of repair, they are a huge burden on our healthcare system. I know that might sound a little bit silly, but it's true. I mean, a lot of patients end up, at some point in their lives, young or old, with some type of tendon and ligament injury. And oftentimes, I think inappropriately, they're sent to wear surgery, right, to explore and see what's going on there. And oh my gosh, look how bad it is. I mean, I can tell you the amount of stories of patients who, have a small tear and then they end up going through this huge hoopla for surgery for no reason, probably, is just insane. On the other end, we can go to physical therapy, which is cool, but again, that may not be solving anything either. You're going to go there for 8 weeks and you're still going to have chronic pain. This is where BPC can come in. Again, we can use it as a targeted mechanism, a way to be really, really precise with patients who are suffering from acute or chronic pain. Again, it's potently anti-inflammatory, right? And it is so systemically speaking. How do I use BPC-157? I classically use that for patients. I tell practically any patient, look, if you're going to have any type of acute surgery done, right, for something, whatever, it could just be, whether it's exploratory, whether it's, we're going to have a knee replacement, I always mention BPC-157 as an option. My younger brother, I'll use him as an example. He was probably 18 years old, playing sports, got a full ACL tear, had their surgery done. I immediately actually started BPC like the week of surgery. So he's immediately, his receptors and all that stuff are being taken care of. BPC-157, by the way, helps upregulate growth hormone receptors. Pretty cool, right? So BPC-157 with a growth hormone secretagogue is sometimes also a really good idea. Fortunately, he was really young, so his growth hormone is pretty solid. But so again, he goes and sees his doc. He's going in to start physical therapy, and his surgeon, who is this, he's a really sweet guy, but he's kind of the classic old cantankerous orthopedic surgeon. He was like, dude, what are you doing? Because I have never seen someone heal this quickly. I've never seen someone move through mobility so much, their strength, and again, he was like, I know you're younger, but like I've done a bazillion of these surgeries and no one has healed at the rate you did. He was doing things, in half the amount of time. And of course, he told him, well, my brother's this crazy dude, and he gave me BPC-157, and it was really cool. He actually was like, that's awesome. Like, I heard about that. So again, it's in the zeitgeist, guys. And even he was really impressed by that. So there's so many other applications for BPC-157, any type of irritable bowel disease, any type of neuroinflammation, autoimmune disease. There is a strong potential that BPC-157 can be helpful there. It's classically given as injections, but for practically anybody who has any type of GI inflammation or GI disease, BPC should be taken as a capsule. It does have really good localized effects that way. So that's a little nugget you can take home with you. So again, I like to discuss this, especially around BPC-157, because I will be the first one to tell you the evidence around BPC-157 is sparse. It's not zero. Okay, so I like to be clear about that. People will say, oh, there's no human data. There is. It's not zero. It's not great. It's not like 10, but it's not zero. It is mostly animal models, some cell culture stuff. But again, I don't think that ought to mean that it makes this completely irrelevant or dismissible, right? It is an area of opportunity. It's an area of opportunity for exploration. And if you understand the mechanism, I think that ultimately is going to help carry the weight. Okay. Frankly, we had to do this with hormone replacement therapy, right? And a lot of the things that we know and love today, guys, were done by brave people who, again, I'm talking like back in the 1930s and 40s when testosterone was first discovered, more or less. They did some things and they had to make some discoveries and whatnot, but in and of itself, what they recognize is testosterone is an amazing molecule. We understand that it has a clear mechanism of action. We understand what it's affecting, and we ought not to just wait, 30 or 40 years for us to finally say, oh, this is really effective. Because guess what? We waited for that long, and then someone said it causes prostate cancer, and then we had to wait another 20 or 30 years for it to come back around, right? Unless you were a brave cowboy and you kept prescribing it during that time. Those were my mentors. So again, I love to play it safe, guys. I'm a very risk-averse person, but where I feel really solid when it comes to HRT, when it comes to peptides is, do I understand the mechanism of action here? Do I understand the physiology? Do I understand what its goal is to some degree? And if we can make it make sense, then I think it really truly does. It carries more weight than you think, probably. And I think that is where I feel really confident and protected in that sense, right? And I'll be honest with you, knock on wood, I've had myself and my mentor, we've been prescribing BPC for a long time. I've never seen, again, I'm knocking on wood, I've never seen any bad stuff happen to any of these people. Okay, we've seen BPC is going through like a phase 2 trial, mostly for GI stuff, but we're giving it in these crazy big doses. There is no lethal dose of BPC-157, zero. We've never seen it. There's at least lethal dose of water, but we've never seen it with BPC-157. So again, there is data, there is evidence. It might not be the stuff that you want in terms of a big, large randomized control trial and all that stuff, but it is out there and it does carry some weight. Let's talk a little bit about GHK copper, or the copper peptide. I think this is like such an underdog. I love GHK copper, but it has right now, I think, a very targeted mechanism. What most people understand what it's used for is for skin, and it's darn good at helping heal the skin, helping to rejuvenate the skin. But the mechanism of this copper peptide, GHK copper, it does run a little bit deeper than that. And again, this is something that we're seeing with the GLP-1s, which I'll get to in a second, that, there seems to be more to this peptide than just weight loss, for example, right? So we know that GHK copper is a very potent antioxidant, and it upregulates gene expression. So again, GHK copper in and of itself, the peptide, remember this, please, none of the peptides by themselves go up and do something, right? They trigger something to occur, okay? So GHK copper classically goes up to cells and knocks on the door, so to speak, and hits the receptor there, and that causes a genetic activation, right? And that could be a turning something on, turning something off. What we know is that GHK copper upregulates gene expression, especially on the antioxidant pathway, which is really fascinating. And again, would make sense, especially with how potent it is at improving skin texture, laxity, wound healing, absolutely. So, we see a lot of patients using GHK copper topically, right? So this is one of the few peptides that works really well topically. As a cream, as a serum. You're probably seeing it now in a lot of your ads, or you will be now after our phones have been listening to us for an hour. You'll start seeing ads for copper peptide serums and hair products and stuff like that. And again, there's good reason for that. It does affect TGF beta, so cytokine modulation as well, right? So not only is it upregulating antioxidant behavior and preventing oxidation, but it's also helping modulate cytokines. Peptides are really cool in that sense too, right? Modulate can be really interesting because it could mean upregulate or downregulate, and it's going to be based on what the body actually needs. Okay, so again, cytokines aren't all bad. We need some amount of cytokine modulation when it comes to an acute injury. We want that site to get inflamed because we want the healing process to occur. We just don't want that carrying on forever, right? That would be systemic and chronic inflammation to some degree. We know that it's involved in the remodeling of tissue, right? So again, we see that potentially going beyond just the skin to some more systemic tissue. Again, that would be kind of similar in its effects or to BPC-157, right? BPC has that kind of similar systemic effect. You can do an injection of BPC-157 and it practically is going to hit you head to toe. And it's going to be looking for areas of opportunity where soft tissue in particular is being affected. We do have some rough data on GHK copper being neuroprotective in animal models. So again, I'm not saying that it's curing Alzheimer's or anything like that in any way, shape, or form, or preventing it. All I'm saying is that we are seeing some really interesting stuff coming out about GHK copper, and it's running deeper than just the skin. So another really cool peptide to be on the lookout for. This is like the best part. And if you're not a nerd, maybe it's not the best part, but if you're a nerd like me, this is the best part of being in our world right now, is that we have all these amazing things coming out, and we have access to the internet. We can constantly see updates, and I want you to be the first people to know what else GHK copper does, so you can apply it to your clinic and to your patients, right? I literally, in good faith, I can't leave this conversation without talking about GLP-1s. Even though I think a lot of us have now siloed them over to just the weight loss drugs. It's a peptide. They're amazing peptides, right? And there are many different types nowadays, but they are so beyond just a weight loss peptide. It's not even funny. So I know you guys know, some of the big ones: semaglutide, tirzepatide, liraglutide. Of course, there's retatrutide, which is going to be the fun, fancy one coming out, sometime maybe this year. The GLP-1 in particular is what I think deserves a lot of the credit, but so do some of the other incretins. But the GLP-1 in and of itself, what we now recognize is that these receptors are freaking everywhere. They're in our brain tissue, they're in our heart, they're in our lungs, obviously they're in our gut, our pancreas. So again, the classic mechanism most of us think of is, GLP-1 kind of signals that satiety, right? It helps you not feel so hungry so quickly, and we kind of slow down the gastric emptying and things of that nature, which is super cool. And it's amazing, right? Getting rid of that food noise is one of the most powerful things you could do for people who just have really bad appetite dysregulation. I can't tell you how many of my patients said, Nico, I feel like I'm not a slave to food anymore. And I thought that's really powerful because, for those of us who maybe don't have that strong of an effect there, it's a tough way to live, right? But the mechanism of action of GLP-1 is so much more than that. Again, what we're seeing now in the emerging research, one that I just wrote an email about this not too terribly long ago, but mast cell stabilization. We are recognizing that GLP-1s effectively, help really disable a lot of mast cell stimulation and aggravation. So in particular, patients with mast cell activation syndrome, or if you've ever seen the abbreviation like MCAS, mast cell activation syndrome. I don't know if you've ever treated a patient with mast cell activation syndrome, and there's not a bazillion of them, but it's more common than you think. And those patients are just sensitive to everything. It's a huge burden on them. It's miserable. Classically speaking, we just throw antihistamines at them and steroids occasionally and just tell them to, like, suck it up and you'll be fine. But it's a miserable life. Hives and itchiness, and it affects their mental health so tremendously. Histamine is so aggravating and it's so inflammatory. It affects anxiety and depression and brain fog. Obviously, it affects your gut tremendously as well. So it's a nasty thing, histamine especially, but kind of stimulated by that mast cell activation. GLP-1s in a case study review, and you'll have to forgive me, I don't remember. There's a handful. I mean, there might be 12 case studies in this review where patient with mast cell activation syndrome takes semaglutide. I mean, typically with semaglutide, I think there might have been a couple who took tirzepatide. Nonetheless, literally within a few weeks, they're saying, oh my gosh, like my mast cell activation syndrome is pretty much kaput. It's gone. Like, I feel amazing. It's the best I've ever felt. And they miss a few doses, or for whatever reason, they stop taking the GLP-1, and boom, the mast cell activation syndrome comes back. So what I'm also saying is it's not curing mast cell activation syndrome in the sense that it doesn't make it just go away. Other than if you're taking it, it seems to stabilize it. But how incredible is that? I mean, it's really cool to read even just the patient's own words in those case studies. We are seeing case studies and just general review studies on its very pro, or rather more like anti-inflammatory effect or pro-inflammatory cytokine downregulation. So patients with rheumatoid arthritis, amazing effects on joint pain. In fact, I think many of you who've probably prescribed a GLP-1, you've heard your patients say, like, I don't know what it is, dude, but my joint pain is like gone. And maybe it wasn't even that bad, but it wasn't bothersome enough. It's totally gone. We know it's also having very potent effects on microglial and vascular endothelial modulation, which is where we get a lot of the protective heart and cardiovascular benefits too, which is profound. And we actually have very solid research on that front, and especially semaglutide, tirzepatide a little bit as well. So, I mean, you can't find a better opportunity than today's market of peptides and a better wheelhouse than GLP-1s. I really think that GLP-1s are kind of the same way we use BPC-157 for like everything. Right? Oh, your stomach hurts? Here, try some BPC-157. Or you have a cut? Here, try this. I think GLP-1s are going to be that way. Oh, you have chronic cardiovascular issues? Here, try GLP-1. Oh, you have a little bit of joint pain? GLP-1. Oh, you have mast cell? GLP-1. That is where I want you guys to start extending and critically thinking and opening your mind to, oh, wait a second. I don't have to just use GLP-1s for weight loss. And in fact, how can I speak to that a little bit more? How can I help patients recognize that too, so that patients are coming to me? And of course, this is all off-label. I'm not saying this is like FDA approved or whatever, okay? But how can I make it clear that the same way I help young men with depression via testosterone replacement therapy off-label, well, could I not do the same thing for a gentleman with non-alcoholic fatty liver and testosterone, or a female with chronic joint pain and a GLP-1? I love thinking through that stuff because it separates you guys. It's the wheat from the chaff, right? I think that's what makes a great provider separate from a good provider. So again, I know I already kind of mentioned this a little bit, but as far as the mast cell activation stuff goes, but also think about PCOS and endometriosis. I talk about this actually quite a bit in my HRT University master course for hormones, because I think GLP-1s are a no-brainer for these patients with PCOS and endometriosis. They have a clear mechanism of action there, and we are again seeing more and more research coming out on that. And this isn't just me just like speaking wildly around that. PCOS, for obvious reasons, it improves insulin sensitivity, which by effect helps lower our androgens, and it helps restore ovulation, and it's going to help improve inflammation, and it's going to help decrease histamine, and right, all the things that we just talked about. that is exactly what drives a lot of the PCOS stuff going on. And that has some pretty dang good data there too. And again, I can speak from my own experience working with my female patients in my own clinic. The power of GLP-1s at so quickly restoring things. And I mean, HRT, you can't beat progesterone and thyroid for a patient with PCOS, but gosh dang, there's a really close second there with a GLP-1. And endometriosis, same thing. What we're seeing now is that endometriosis, of course, is a massive inflammatory effect from tissue migrating out, God forbid, into these poor young ladies all over the place. But what we're seeing is that the endometriosis is having a quieting effect via the GLP-1 receptor, right? We see reduced peripheral aromatization, meaning we don't get as much estrogen becoming activated. And this is where y'all need to take Estrogen University, because I talk about this a lot. Estrogen is so inflammatory in that setting, in that set and circumstance, that it actually promotes the worsening of that endometrial tissue formation. So if we can quiet that, if we can stop that extra aromatization, and if we can heal that with some progesterone and thyroid, now all of a sudden we have this really great way of helping these patients without just saying, you know what, we gotta cut everything out of you, or put you on some godforsaken type of birth control that's just going to squash everything and make you feel like the shell of a person. I'd much rather help restore that patient, and I don't see why we couldn't use GLP-1 for that. Okay, I'll get off my stump speech there. So again, the clinical takeaway to some degree, or the clinical judgment, it is important here. Okay, flinging peptides willy-nilly at everybody is not a good idea. Okay, and I don't recommend that for anything, to be clear, right? I don't think everybody should take Tylenol for every ache and pain. I don't think everybody should take hormones just because they have bad mental health. Like we have to recognize what is going on with the patient. We have to do a full assessment, all the good stuff, right? And especially before we think peptides, can we think some of the foundational stuff? Can we think about HRT? Can we think about what specifically are we trying to target that this peptide very much specifically addresses? And again, we can pull from the literature here, guys. We don't have to just totally go off our feelings or vibes. We can literally say, hey, the reason I'm using tirzepatide off-label for this young lady with endometriosis is because the literature supports that. I know it's not FDA approved, but it supports it. I'm not making this up, right? We need to understand the evidence, and we need to understand it honestly. Okay, so that's why I'm coming here saying, hey, look, I understand BPC-157 isn't the end all be all when it comes to evidence, but it's not zero, and I am confident in the mechanism of action, and I stand behind it for those reasons, right? And of course, we need patients that need to be consistent and willing to comply with the protocol. I don't know if I need to really say that, but it matters, right? Don't oversell something. Please never oversell things to patients, right? A lot of patients are desperate and they want to feel better, and they do, but don't give them something that they really don't need just because it sounds kind of sexy, right? Right. So again, if a patient's not ready, they're probably hormonally destroyed, right? And that needs to be addressed. And so does their lifestyle and diet. Are we just looking for a shortcut here? Or like those are all the things that we want to avoid, because patients are more and more, just like patients are coming to you for HRT, more and more patients are going to start coming to you for peptides. And they're going to say, hey, I heard it from a friend. I saw it on TikTok. I read about it on Instagram, whatever. And you want to say, that's amazing. That's awesome. I love hearing that. I freaking love peptides. Huge fan. What do you got going on? And let me see if I can help. And I just want to make sure that's actually the right choice for you, because I got a whole lot of other cool things that we can utilize, like HRT. So think about that. You're now opening up, even from a business perspective, you're opening up this massive opportunity for your business and for your client, for your patient to be better, right? Wouldn't you rather have them on HRT for the rest of their life because it's the right thing to do and they're going to be so rewarded by that? And now you can also then say, hey, if at any point you encounter these things or you come up with these problems, there are also peptides for that too. Win-win in my book. I want to try to just give, quickly before I end here, like a little bit of a case study here. So a female patient of mine who I love, I've been seeing her, probably the last 3 years or so. You know, she's in her 60s, early 60s. She's very healthy, but just chronic autoimmune stuff, especially in the form of rheumatoid arthritis. It's really, really gnarly. She is really fit. She's super healthy. She works out every single day. She eats clean diet. She sleeps 8 hours a night, all that stuff. We got her HRT perfect. I mean, she is super optimized there. She was having all kinds of recurrent UTIs and vaginal dryness and all kinds of terrible stuff. She wasn't sleeping that well, right? So when I met her, we got her HRT foundation solid. We got that done first, okay? And then she's saying, Nico, I'm feeling so much better. In fact, just by the HRT, the estradiol and the testosterone has made my joints so much more comfortable, but they still hurt, and they hurt a lot. And you know, she was on some classic rheumatoid meds and things of that nature, and it helped, but not enough to where she wasn't in chronic pain. So I said, okay, I know a few things that we can do. BPC-157 was a no-brainer, especially because she had just come out of a knee surgery, and that was really killing her, right? So she now has like acute inflammation on top of chronic inflammation. So I said, let's target that, because that was her priority number one, is if you can freaking make my knee stop feeling so bad, that would be helpful. So BPC targeted, joint integrity, all that good stuff, boom, so much better. Okay. Okay, so we get through that hump, and she's saying, okay, Nico, that was great, amazing. My right knee's feeling so much better now, but again, I'm still struggling, and just with pain, especially just kind of systemically. You know, sleep is definitely better with the progesterone. It's just not amazing. Energy's pretty good, but again, just because of this rheumatoid, I just feel like I don't sleep as deeply enough because I'm in pain all the time. And so I thought about this, and I said, okay, what's a beautiful systemic healing peptide that's going to hit pain, that's going to help heal, that's going to help recover, that's going to help with energy, it's going to help with sleep. And I said, okay, in my Rolodex, I'm landing on Sermorelin. I love Sermorelin. It's readily available. Let's give it a go. She is now basically just on 1 aspirin a day as far as pain goes. And she takes it, and she says, I don't even know why I take it. I think it just makes me feel better. She's off all of her rheumatoid meds completely. It was unfreaking believable. And that was within 3 months. If she stops taking, now this is interesting, if she stops taking the Sermorelin, even for just she can go about 3 weeks without it, and then immediately falls right back into chronic pain and significant inflammation. When she takes it, she's good. So the next question was, of course, well, Nico, can I take this stuff forever? Right? Well, so glad you asked. You can. Yes, you can. You don't need to even take breaks from it, because Sermorelin has such a natural pulsatile rhythm, because remember, it was developed for kids for the very same reason, to keep that natural rhythm, that this isn't something we have to like come off for 5 weeks and come back on and cycle through and things of that nature. So yeah, she can take it, and she takes it every single day, and it's just a miracle drug for her. It's just been absolutely incredible, and the healing that it's given her, and it's really just restored her life. So if that gives you any sense of confidence in what we're doing with peptides, I hope that one does. So again, there are some things I've changed my mind around, right? Higher doses, not always necessary. In fact, lower doses can sometimes act just as beneficial and be more targeted, right? Stacking 1,500 peptides on top of each other is not necessary, okay? That's, again, no different than me throwing 500 supplements at someone. Pick out the ones that make the most sense for the targeted approach, okay? Monitoring does matter. We don't need, and I get into this in the course, we don't need to draw 500 different labs just based on peptides, but keep up with your patients. Is this helping? Is this working? Can we create some measurements, whether it's subjective measurements on pain or visual objective measurements on scar tissue healing? And then, of course, guys, informed consents, okay? Make sure you have solid informed consents. You can see my friend Courtney Walker, court-approved counsel. I'll tell you all about her. She's amazing. Most of you probably already know her. I'm not a lawyer, so I'm not going to speak more than that, but you need to have informed consents, okay? You need to have informed consents for peptides, period, end of story, and you need to chart like you mean it, and you need to have the data and the research and the confidence to back that stuff up, okay? So I'll talk about this just super briefly here, because I know we're running a little bit late on time here. So I already kind of talked about this, but right, start with the HRT audit. Start with really understanding what's going on with this patient's foundation. And then from there, maybe one peptide at a time. Be really targeted. If you're going to stack peptides, make sure it's targeting very specifically. Right? Get some benchmarks, get some metrics, identify any other gaps there, right? Educate, 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 and of course, know when to stop. Compounding pharmacies, another no-brainer, guys. Know your pharmacy. That's on you. That is not on the pharmacy, just FYI, okay? If you're a business owner, you're a clinic owner, you're a provider, you need to know who you're getting meds from. You need to know the quality of standards. Just like there are bad doctors and bad nurse practitioners and bad everybody out there, there are really bad pharmacists and really bad pharmacies. On the flip side, there are also really, really, really good ones, okay? And they're actually not that difficult to find. You just need to know what you're looking for. Understand the difference between a 503A versus a 503B compounding pharmacy. Are they doing testing on their products? Real testing. If they're doing research use only or physician use only, no. Especially if you're a nurse practitioner, good luck defending that in the court of law, okay? You need to have a really healthy, reputable pharmacy that's been around the block and they understand the prescribing language, they understand all the ins and outs of that stuff, okay? That relationship is extremely critical, okay? Partner with the pharmacy, and I have no shame in suggesting optimal balance. They're amazing. They're our partner for tonight. They're the reason why I'm here talking with y'all, okay? So get that quality and transparency. Make sure they have a good provider workflow, right? Pharmacists are our friends, guys. Like we can lean on them and they us, right? We want that really healthy clinical partnership. We want the guidance. We want the ability to say, hey, I feel confident not only in just what I'm presenting to the patient, but also what my pharmacy is going to be able to present, right? I think that's a no-brainer, guys. So, guys, I want to thank you sincerely for being with me today. It's been just such a pleasure. Here's a beautiful little QR code here. So any of you folks who want some follow-ups and reference materials and all that stuff, Optimal Balance is going to provide that for you all tonight. And of course, we'll provide lots of information on HRT University as well. And I think this is a match made in heaven kind of thing. So with that, Chris, I will kick it back off to you, sir.
Yeah, Nico, thank you. That was excellent. I think tonight showed just how much interest there is in the space right now, and a ton of engagement throughout the presentation, and clearly a lot of curiosity around peptides that are being thoughtfully integrated into modern practice. So, thank you to everybody. Thank you, Nico. That was great. Apologies about the blurriness of the slides. We put the slides in the chat. It'll be in the follow-up email with the recording. Once we put the recording on YouTube, it'll go out to everybody that registered for the event and attended. So we'll get that out to everybody as soon as we chop this up and throw it on YouTube, hopefully by the end of the week, if not early next. HRTU link is in the chat as well if you'd like to learn with Nico further. I mean, I know I would. I wish I was a clinician so I could sign up. So that is clinician only. I might have to sneak in with one of you guys if you can let me join one day. Don't tell Nico. But in all seriousness, want to jump into some questions and some Q&A. I had some good questions that I'll go back to. I know there was a question of common side effects. Nico.
With one peptide
Nothing particular, just in general.
Yeah, I mean, gosh, that could be a lot. I think probably most people already know common side effects of like GLP-1s, right? Nausea, vomiting, things of that nature. BPC-157, arguably speaking, we really don't have any known side effects outside of like hypersensitivity reactions, which occur with any type of medicine or whatever you could give. The growth hormone secretagogues are pretty interesting. They have different flavors, of course, depending on what you're using. So if it's sermorelin versus tesamorelin, radically different in some ways, just in terms of the intensity. But really common ones are, again, the sleepiness, grogginess, which is, again, typically why you'd want to take them in the evening, right before bed. Joint effusion, essentially, or joint swelling can occur for some patients. Again, that's almost always because of a fluid balance shift. So that's another really common thing that you could see with growth hormone secretagogues, just broadly speaking, again, is a fluid shift. Again, that's not necessarily a bad thing or dangerous thing or anything like that, but it can get to a point where it's just uncomfortable, and you might need to use diuretics or things like that. I've never had that happen. This is very typical of clinics who go with the biggest, largest dose possible. So there is actually a means of considering titration even for the growth hormone secretagogues. If we do want to end up at a dose that's a little bit higher than, say, a very conservative dose, just titrating up, every couple weeks, similar to what we would do with the GLP-1, seems to help keep that at bay. So, trying to think of any other really prominent ones, but those would be ones that I would really consider again for the growth hormone secretagogues. And then even with the GLP-1s, there's been some talk about them causing some depression and anxiety and things of that nature. And the data is a little bit iffy on that. I think a lot of that typically has to do with how much of a caloric restriction is occurring, how much nutrients and just general macronutrients these patients are missing out on. If they happen to already have kind of a disposition there, again, this is where I'm typically saying, well, did anybody look at this person's thyroid or testosterone? Like, these are probably patients who really needed to start with hormone replacement therapy first to help prevent anything gnarly from happening from the GLP-1 side of things. So I hope that's helpful, guys. I know that's a little broad, but yeah.
For BPC injections, where do you recommend injections for back pain, for example?
It's a good question. Again, there's a very small and frankly not very good study that was done with BPC-157 out of a wellness clinic for intra-articular injections, so right, like a knee injection. Now, that study at the very least pointed to, number one, you can do that, and number two, it doesn't seem to cause any negative effects there, and number three, maybe hypothetically, that has a more targeted action than if we just say do a subcutaneous injection. What I can tell you just from my own anecdotal experience is that injecting into the subcutaneous tissue does have systemic effects, and I have seen patients heal. Again, my brother being an example of a knee replacement surgery. He did subcutaneous injections in the belly, and that was well enough for his knee. That being said, I do have providers who use them intra-articularly, which is, again, it's a little bit more of a procedural to do. So if you feel comfortable with that, that's fine. But, there are things like back injuries and stuff like, okay, is a patient really going to be, is a patient going to be able to do that? Or are you going to do that for the patient every single day? I think it just becomes kind of goofy. So I still recommend subcutaneous injections for BPC and letting the systemic action just occur.
On peptides, you had mentioned, taking them long term, but do you have any more comments? And you touched on it briefly, but any more comments on cycling certain peptides?
Yeah. So, excuse me, guys, I'm getting a little bit of cough. The peptides that in particular. So, okay, let me back up here, because what a lot of providers may recognize is that if they've ever ordered like CJC ipamorelin or tesamorelin, it might recommend 5 days on, 2 days off, or things of that nature. Most of the time, the reason behind that is it's mostly theoretical, meaning that this really hasn't been deeply evaluated in any of the literature. The vast majority of peptides like tesamorelin and sermorelin, which were FDA approved, were meant to be taken every single day. Sermorelin, we already kind of discussed, it has a pulsatile nature. So it is not just driving your growth hormone up for ever and ever and ever, every single day, all day long, unlike, say, tesamorelin, which could do that. It does do that. So sermorelin especially can be taken daily and does not need a break. Tesamorelin, again, the literature was never meant to say, hey, take this drug for the rest of your life. It was really more of a targeted approach. That being said, it could make some sense. And again, I'm trying to be fair here. It could make some sense to take 2 days off a week. I don't do that with my patients. I've never seen any negative outcomes with them taking it every single day. What might make more sense is taking at least 2 to 3 weeks off after a cycle of tesamorelin, for example. So if you use tesamorelin for, say, 8 to 12 weeks, it might make some sense to then take 2 or 3 weeks off. And the idea would be to let the growth hormone receptors, resensitize, so to speak. Again, a lot of that stuff is very, very, very theoretical. and a little bit touch and go from what I can understand in the literature. But again, with things like sermorelin, literally in the studies, that's what they looked for, and they found no ill effects with taking it daily, and that could be used long term.
Do you have any information or experience on the growth hormone peptides in patients with pituitary adenoma?
Well, that's a good question. I don't. So to be fair, I've never done that with a patient with a pituitary adenoma. That would probably be one of those patients I would rather err on the side of caution. I'm pretty good with the literature on that front. I don't know of any studies that's even evaluated that. I personally, again, just from my own conjecturing, I don't think it would cause any significant problems, but it wouldn't be someone I'd be willing to test that out on.
There's some comments on, injection site pain being common. Let's see, other questions. Does not look like many other questions, unless I missed. Okay, here we go. 28-year-old female, IGF 144, 260 pounds of tirzepatide 15 milligrams every week, and Tessa ipamorelin at bedtime 3 days a week, unable to lose more than 20 pounds. Any additional recommendations?
That's a good question. I mean, there's a lot there. Number one, have you evaluated hormones? I think that would be very, very worth considering as a foundational approach. Number two, this is I think at least well known, anecdotally speaking. If a patient just has not seemed to reach any wellness when it comes to tirzepatide in terms of weight loss, like maybe she has lost a bunch of weight and now has stopped. I don't know if that's what you're implying. It is occasionally reasonable to change to a semaglutide, for example. There are patients who just seem to tolerate one more than the other and benefit from one more than the other. So that has been my approach, generally speaking, is let me get the foundation there. Let's see if there's some HRT stuff going on, and occasionally even just taking a little bit of a break. Again, kind of the same strategy would be with the growth hormone secretagogue. If there is such a thing as receptor sensitization and desensitization that's really robust, maybe taking a couple weeks off might prove beneficial. But anytime I've ever stalled with someone and I move them to a different GLP-1, that seems to do the trick.
Sorry, Q&A people, I was so caught up in the chat, I missed the Q&A, the actual Q&A section. So sermorelin dosing for sleep in men and women.
I mean, again, I don't like to give too much specifics there, but I would say that most of my patients with sermorelin, I would typically say, oh gosh, I think maybe 300 micrograms a night. It's a pretty good dose. I get them mixed up, guys, so pardon me for not knowing that off the top of my head. I think between 1 and 300 micrograms of sermorelin is a pretty sweet spot. Sermorelin is so gentle that I'm not nervous about taking that to a slightly higher dose. Whereas with tesamorelin, that is where I've seen, especially if you take it too high too quick, you'll get a lot of the fluid shifts and things of that nature.
Great. Does PT-141 help to optimize sexual performance for patients with dual diagnosed conditions, such as HDN and IDDM2, or additional modalities generally utilized?
It does. PT-141 is, I talk about this, actually, I have a whole section on that. I know HRT University is really HRT specific, but we have a module on, or a section on, sexual health and wellness. It does work. It doesn't work for everybody. A lot of times it's just a error on the side of the patient or the prescriber. PT-141, a lot of times patients will take it and then immediately try to have fun and nothing happens, and then they get sad and depressed and stuff. There is a time frame of about, probably about 30 minutes where you really need to wait before you were to do anything for it to kind of kick in, more or less. And that has been one area of opportunity that I've seen once I started education, because I didn't educate patients on that well enough. And they were really disappointed, and I was like, this stuff doesn't even work. And then once I started telling them, hey, take it, wait about 30 minutes or so, before engaging in sexual activity, it can be really helpful. I have not seen it play out as like the end all be all to hyposexual disorders and things of that nature. So I can't even speak to the fact that it's, for what it's FDA approved for, it's good. I wouldn't say it's amazing. And for some patients, it just flat out doesn't do much.
If a patient is on sermorelin treatment, can he also continue his HGH cycle?
Ooh, say that one again, sorry.
If a patient is on sermorelin treatment, can he also continue his exogenous HGH cycle?
I don't think it would make any sense. It would probably cancel each other out to some degree. So I would just pick one.
What do you recommend for women searching for HRT with a history of clotting disorders? I have a history of factor B and was taken up by combination.
Yeah, that's a really good question. I probably speak about that for probably close to 30 or 45 minutes in the course. It's very nuanced. I'm not going to speak to your case specifically, but estradiol and even oral estradiol, and again, I'll make a controversial point here, has never been shown to cause an increased risk of clots in women. So statistically speaking, that it's unbelievably relevant at all. And that is based on long-term observational trials and randomized control trials. So, and that is even including women with any thrombophilia or things of that nature, clotting disorders, whatever. It is practically speaking a no issue as long as we really truly understand your medical history and it's a shared decision making. But and again, if you're like afraid of oral estradiol, that's totally fine. Even though oral estradiol, again, classically speaking, has never been shown to increase the risk of clots in a long-term or observational controlled trial, you can still use topical estradiol. So, but yeah, I'm a big fan of estradiol and hormone replacement therapy for women, regardless of clot history and things of that nature, because we can hang our hats on that when it comes to the literature.
Are peptides contraindicated in patients with precancerous skin lesions?
It's a fair question. I would argue that anytime anybody has a malignant anything, I don't think you're going to find a good way to say, yes, this is going to be worth pursuing, even with HRT, right? I mean, there's a medical reason for it, and then there's a litigation reason we have to consider. And so if I'm using peptides, I'm using them off-label, and they're maybe even more on the experimental side of peptides, I would not pursue using it on someone who has active malignancy of any kind.
What are your thoughts with GHK copper in clients with histamine issues?
GHK copper histamine issues?
Correct.
So to be fair, I've never treated anybody, like I've never treated a mast cell patient with GHK. So I've never come across that issue. Most peptides, sermorelin is famous for this, and GHK copper as well. Maybe this is what they're getting to. When you inject it, it does cause a local histamine reaction, and that's usually just a pH thing, meaning it's a little bit more acidic than the environment it's being injected into. It causes a little bit of burning, stinging redness. It can even kind of look like a little bit of a welt, and then just goes away over time. So again, that would be a localized reaction. That would be normal. That would be expected in a vast majority of patients. But I can't speak to directly to that question because I've never seen that, and I wouldn't presume that GHK copper would cause, outside of a mast cell activation patient who are sensitive to everything, I don't think it would cause such significant harm to anybody with a little bit of histamine reactivity.
Can you discuss briefly labs you would do prior to starting peptides?
That's a good question. A lot of people ask me, do you consider IGF-1 and checking all that stuff? I don't. I don't, and it's mostly because, again, as far as IGF-1 is concerned, it starts acting a little bit like testosterone labs. I mean, we can check it. It's going to be high. Are you going to freak out about that while you're taking a peptide like a GH secretagogue that's going to cause that? So what I'm typically more interested in looking at, if we're going to do labs, say for GLP-1s, for example, or things like fasting insulin and maybe triglycerides. And, certainly we'll look at triglycerides for patients taking tesamorelin because that's really effective at lowering triglycerides and for fatty liver and things like that. So there may be some targeted labs there, but I do not have a blanket like we must do these labs before we take peptides, and then we must monitor them very frequently afterwards, outside of some of the more metabolic labs. And again, I'm doing that mostly because, of course, I'm trying to work on their overall health rather than just am I looking at the the repercussions of this peptide.
How soon, give or take, do patients start seeing a difference or results with BPC?
Well, that's a good question. BPC is, I actually, I don't think it works that fast. I would say on average, I tell patients to wait at least 4 weeks. Even after stopping BPC-157, patients can oftentimes see continuing residual results from the BPC-157. So I would say at least 4 to 8 weeks before I would completely throw it out the window.
Thoughts on NAD taken along with the GLP?
Great. Yeah. Yeah. I mean, I like NAD. Yeah. There's certainly no issue with that or contraindication.
Best peptide for chronic fatigue?
Ooh, that's too hard of a question. I don't know. I don't. Again, chronic fatigue is. I'm not saying it's not a real. It's a very real thing. I think it's just a little too vague. There's so many things that could lead to that could cause that. I don't think there is a peptide that could be so specifically targeted towards that. Again, we could consider things like MOTS-c and some of those types of mitochondrial peptides as being beneficial, but because chronic fatigue syndrome is so vague, it might be better that we use something that's more anti-inflammatory or antioxidative. So I don't know.
How bad is rebound pigmentation that can be caused from PT-141?
Ooh, that's a good question. I personally never run into a case of it, and frankly, I don't use a ton of PT-141, so I don't know if I'd even be the best person to answer that question. So I don't know. Yeah, it's a good question. I'm sorry, I don't know that one.
Do GLP-1s cause metabolic relapse once stopped, i.e. worsening metabolic health due to loss of muscle mass? Best to combine with, GHRP.
Yeah, I kind of see where you're going with that. Yes and no. So GLP-1s enhance mitochondrial output, which is really interesting. Now, of course, if you are in severe caloric deficit and you're losing tremendous amounts of weight and you're losing a lot of lean muscle mass, well, of course, that could cause, metabolic dysfunction to some degree, or at least the worsening of the metabolic health. So your question is a good question. There's almost like two categories to discuss there. So of course, if we're dosing it appropriately and the patient's not losing tremendous amounts of weight, generally speaking, the metabolic health and overall health of the patient is preserved. Do I think a growth hormone secretagogue is necessary to have in addition to a GLP-1 every time? No, I really don't. In fact, I think testosterone does a great job of maintaining lean muscle mass, again, at a more foundational level. But certainly we can utilize growth hormone secretagogues in a targeted approach if a patient is just really susceptible to losing that weight, or they're already quite sick and we're using the GLP-1 for, say something more like inflammation rather than, say, weight loss specifically.
Looks like we got a couple more. Chronic tendonitis. So BPC plus TB500 or BPC plus TB500 and KPV, which combo would be better?
That's a good question. I like BPC. TB500 is an interesting one because the research is basically non-existent on TB500. I know that's going to sound kind of controversial, but there really is, and I love literature. There is no literature basically on TB500. Thymosin, what is it? Thymosin beta 4? God, I'm sorry, I'm so combobulated with names here. That is the actual peptide that we have tremendous amounts of literature on. TB500 is really just a fragment of that.
Correct.
And it was really mostly in animal models that we were looking at that with. So again, it's just super sparse. I've messed around with it a little bit, and again, BPC is so effective, I can't really tell if it's adding much additionally to what the BPC 157 is doing. Now KPV, on the other hand, is also real that we do have quite a bit of literature on. It's really, really effective. Again, as far as joints and tendons go, I would still just opt for BPC 157. Again, that's just me personally. Whereas KPV, I have seen a lot of literature around KPV in terms of gastrointestinal stuff. So BPC 157 capsules with KPV, that's a really, really good one for like IBD and things of that nature.
What are your thoughts on the growing theory in the peptide and longevity space of combining SS31 with other peptides may enhance overall responsiveness and outcomes?
I think it's interesting. I do. I mean, I think it's interesting. You know, it's a cool theory. Anything that could increase or potentiate mitochondrial and metabolic output, I mean, in general, that ought to make everything run better and run smoother. I don't, again, I wouldn't say that I feel so strongly that's the effect that I would just throw SS31 at absolutely everybody, if that makes sense.
All right, a couple more rolling in. We're getting close to time. What peptides do you use for chronic fatigues and stopping TRT due to fertility issues?
I hit on the chronic fatigue one a little bit. What was the second part?
To use for chronic fatigues and stopping testosterone due to fertility issues. Maybe an HCG.
Oh, okay. So if I think the question is, a guy stopped TRT, now he has chronic fatigue because he stopped his TRT.
Yes.
So what I would say is, don't stop TRT for fertility issues unless that is very clear that you did all the things that you could do while he was on TRT. So what I mean by that is TRT, by the way, TMI maybe, but my wife and I are expecting baby number 3. I'm on TRT. You add HCG. I talk about this in great detail in the course because everybody should know how to do this for young men. You add a little bit of HCG in. It takes about 75 to 90 days for sperm maturation to occur with HCG and TRT. The vast majority of young men, otherwise healthy and well, are going to have adequate sperm levels and no problem with fertility. Zero. Absolutely none. If he comes off TRT for fertility reasons and there's something outside of that, I mean, consider enclomiphene at the very least. But you're not going to find a way to cure that. It's a foundational thing, right? He needs testosterone, so let him have it, kind of thing. And it's amazing when you recognize that TRT is not it's not destroying a guy's testicles. It's not making them explode. It's not making them shrivel up into nothing forever and ever. It's a simply temporary thing, and you add HCG and it comes right back.
If BPC is slow, then for acute surgery, would you start the patient in it in a few weeks pre-op?
That's exactly what I do. Yeah. Yep. So I typically start at least a week or two preoperatively. I think is totally fair.
Women with stripped ovaries, do you recommend hormone replacement if they've stalled on weight loss with tirzepatide and thyroid is optimized?
With striped ovaries?
Striped ovaries?
I don't know what if you were saying stripped, like they have no more ovaries.
It's a new one to me, so I wasn't sure.
Okay.
Well, maybe we can get some clarification and try to come back.
Yeah. I just want to make sure I'm not misreading that one or misjudging that one. If you're saying she has no ovaries, yeah, HRT. I would be like, if a patient doesn't have a pancreas, should we give them insulin? Probably, yeah, 100%. Well, there's a study. I posted this. Actually, I think it's an email that I wrote. I think we're sharing on it in a podcast here soon. But there's a really good study fairly recently. It was being circulated pretty well on how the addition of HRT, specifically estradiol with tirzepatide, helped women lose more weight than just women on tirzepatide alone, especially if they're in menopause. So, yeah, it's potently helpful at losing weight.
Let's wrap up with this one. What do you do for patients now have lost 100 pounds on max dose Zepbound for the last 2 years, now feeling intolerance, increased hunger, and gained back 40 pounds, no other changes, the lab's optimal?
Yeah. There are patients who are just, again, there's so much going on with it there, so I want to be very clear. I'm overgeneralizing here. If there is a patient who has lost weight on a GLP-1, they did well for a while, now they're gaining weight back, if that's what I'm hearing, I would absolutely consider that if they have difficulty maintaining that diet and lifestyle transition, whatever, I see no reason why they could not continue taking Zepbound, which is tirzepatide, long term, especially if it is protecting them from metabolic dysfunction. And again, it can be a maintenance dose. I'll be talking about this quite a bit in my course, but it's pretty straightforward. Find a dose at which that patient receives all the benefits of tirzepatide in terms of food noise cancellation, anti-inflammatory, blah, 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 but they're not actively losing weight.
Sounds like the hunger is coming back, is what they're saying.
Yeah, if the hunger is coming back, we simply again, if they're not taking tirzepatide anymore, I would put them back on tirzepatide. Yeah.
All right, so everyone who joined us tonight, and I mean especially Nico, thank you. That was phenomenal. Everyone who joined us, really appreciate it. Thank you for spending part of your evening with us. A couple of reminders before we sign off. First, the replay will be available on YouTube ASAP as soon as we chop this up, and then we'll send it out to everyone who registered. And second, put in a link in the chat if you're interested in working more with Optimal Balance Pharmacy. We'll have a rep reach out to you with more information and potential account opening form so you can start that process. And as well, HRT University, Nico's educational programs caught your attention tonight. We'll make sure you have that information too. It's in the chat. And yeah, really appreciate everyone being here tonight. Have a great rest of your evening and save the date for June 24th for our next peptide webinar. Everyone that attended tonight will also get an invitation for that. So thank you everyone attending. Thanks for hanging in there on the blurry slides. We'll make sure we have that resolved for the future. The slides will also be available in the follow-up with the recording link. And Nico, thanks again.
Thank you all so much. Apologies for the blurry slides too. Hopefully that gets fixed. Hopefully my voice was enough to capture your attention for such a long period of time. So you all are wonderful. Thank you. It really means a lot.
Thanks all. Take care. Have a good night.
Good night, guys.